Welcome to Multimodality Imaging Conference. We're going to discuss mitral regurgitation. I'll start by discussing evaluation by echo, and then Dr. El-Tallawi will discuss evaluation by CMR. This is a QR code, so you can evaluate this lecture. I'll give you a second to capture that. All right, so I'm going to discuss echo and role of echo in MR assessment, but we'll also explain why MRI is important. So this is a quick question for you guys. How severe do you think this MR is, based on the couple of views that I'm going to show you? Is this mild, moderate, severe, or it's hard to tell? Do you see any mitral regurgitation? Yes, okay, it's here. There's a jet that's directed anteriorly. I'll give you some apical views as well. How severe is this mitral regurgitation? Is it mild, moderate, or severe?
It's at least moderate.
Based on what?
The color and the angle of the jet is going anteriorly.
So if you look just purely on the basis of the color, I'm going to show you the TEE for this patient with a T. I'm just showing this Doppler when you're assessing MR severity, and this is a very important point. Always assume that the MR is significant, and then try to there is not significant MR Doppler. Same patient with P3 flail by 3D right here, and the severe MR jet. So how do you approach MR evaluation? First, you want to define the mechanism, determine the severity using multiple parameters as mentioned in the guidelines. evaluate for the consequences of a significant lesion, and then determine the timing and management options based on the findings that you're going to describe in your report. And I want to refer you back to the ASE guidelines for the non-invasive evaluation of native valvular regurgitation. Many of our faculty here were authors on this important document, so make sure that you review it. Very nice figures and tables and algorithms for assessment of MR. So remember that the mitral valve is a complex structure, and it's actually made up of multiple components, including the leaflets, the annulus, the papillary muscles, and the cords. And MR can be broadly categorized into either primary MR or secondary MR. Primary MR could be due to leaflet perforation or cleft. That's going to be your Carpentier type 1. Type 2 is the one where you'd get mitral valve prolapse as an etiology for mitral regurgitation. Type 3A, as in cases of rheumatic valve disease, mitral annular calcification, and drug-induced MR. And then type 3B is where you have restricted leaflet motion in systole. The second type is secondary MR, which could be either ventricular or atrial, and we'll talk about the different types. But this is basically when you have normal leaflets, but then you have annular dilation secondary to LV or LA dilation. And 3D imaging is very important when you evaluate the mitral valve, especially when you're doing a TEE. This is a surgical or en-face view of the mitral valve, looking at the valve from the left atrium. Your anterior valve will mark the anterior leaflet, and then your interatrial septum would be your medial border, and the left atrial appendage would mark your lateral borders. And then you would determine which scallop you're evaluating. Those scallops that are closest to the septum, think of a flipped M, would be your A3P3. And the lateral scallops are the A1P1. So this helps you localize the site of pathology when you're doing a TE imaging. And these are some examples of pathologies. This is a P2 flail. This is A2 prolapse, and this is A3 flail. Again, these are different 3D images demonstrating sites of pathology using 3D imaging. This is a case demonstrating a mitral valve cleft in the A2 region. Again, this is sometimes easy to miss if you're just doing 2D imaging. So if you have a case of unexplained mitral regurgitation, the leaflets look fine, the annulus is not dilated, 3D imaging can help you unmask this important pathology, which is presence of a cleft. Examples of primary MR, which we'll discuss in greater details as part of the MRI talk. This is a case of bileaflet prolapse. You always want to assess for mitral valve prolapse in your parasternal long axis view, where you have the displacement of the leaflets 2 millimeters above the annulus. This is the apical view demonstrating that MR jet. And you always have to look at the timing of the jet, especially in patients with mitral valve prolapse. If you look at the CW here, you have a mid to late systolic mitral regurgitation. So at the beginning phase of systole, you basically don't have any flow, no mitral regurgitation. So now look at it again here and there. So the beginning part of systole, you don't have any flow, and then the jet is happening mid to late systole, and that has implications on your quantitation of this MR severity. A TE demonstrating Barlow's mitral valve disease, a myxomatous mitral valve, where you have bileaflet prolapse with significant anteriorly directed mitral regurgitation jet. So whenever you're describing your mitral valve, you always want to include the mechanism or etiology as part of your report. The report cannot treat normal mitral valve, severe MR. That doesn't make sense. So as part of the report, you always have to determine the mechanism. And if you see significant MR by TE, but you're not sure what the mechanism is, you would say significant MR, unclear mechanism, and then you would recommend additional imaging. This is a case of fibroelastic deficiency. This, unlike Barlow's disease, you have a focal flail as a result of chordal rupture, and you have MR as a result of that. So different etiologies of mitral regurgitation. This is a case of a posterior leaflet flail with quite a wide flail gap. And this was treated with edge-to-edge repair. We put in 2 clips at A3P3 here with improvement in MR severity. So again, determining the etiology of mitral regurgitation is important. It helps you determine the severity based on the different limitations you have for each pathology and helps you determine the best management plan. Other less common causes of primary MR, which you want to always consider, include carcinoid heart disease. We see it more frequently on the right side, but if you have an interatrial shunt, then you can get left-sided disease. This is, you see that the mitral valve is thickened, and there's a coaptation gap. Radiation-induced mitral valve disease can also give you mitral regurgitation, and in these cases, you have calcification of the aortic valve, you have heavy calcification and thickening of the mitral aortic fibrosa, and thickening of the anterior mitral valve leaflet. A parachute mitral valve is an example where two leaflets are attached to one pap muscle. So always also think of congenital causes of mitral regurgitation. Functional MR can be divided into secondary MR versus atrial functional mitral regurgitation, and Dr. El-Tallawi will discuss this in greater detail, but basically secondary or functional mitral regurgitation is a result of LV dilation and LV dysfunction, where you have annular dilation and bi-leaflet apical tenting, and you can see this in patients with cardiomyopathies, and you can see this post-MI as well. Atrial functional MR is an entity that's more commonly recognized nowadays, and it's commonly seen in patients with AFib or HFpEF, leading to LA dilation, and this could be a cause of mitral regurgitation in the setting of enlarged LA, but normal LV size and function. This is an example of severe functional mitral regurgitation by TEE. You see that the LV is dilated, and there's significant systolic dysfunction. You can see that the leaflets are apically tethered, where there's a coaptation gap, and there's significant posteriorly directed mitral regurgitation jet. And 3D imaging kind of demonstrates the same thing. Your leaflets are tethered, and there's annular dilation. Again, this was treated with edge-to-edge repair. We put in 3 clips, and there was improvement in mitral regurgitation from severe to mild to moderate. Papillary muscle rupture is another cause of mitral regurgitation. And remember that the anterolateral pap muscle has dual supply from the LAD and the circ, while the posteromedial papillary muscle is supplied by the PDA, so therefore more likely to rupture. And this is a surgical emergency when patients are having MIs and they come in with papillary muscle rupture with significant mitral regurgitation. So always examine your patients presenting with chest pain and MI. Acute MR can be easy to miss, so make sure that you examine them thoroughly. How do you evaluate MR severity? We've discussed the etiology, which should be part of your report. So what are the parameters that you would rely on when you evaluate MR severity? The case I showed you earlier just demonstrates that you cannot only rely on color Doppler, but it is one of the parameters that you would use. And the regurgitation jet area by color Doppler is influenced by multiple factors, including the transvalvular pressure gradient, the phenomenon of entrainment, and the Coanda effect when you have wall-hugging jets. So these are things that you have to keep in mind when you're looking at the color Doppler for patients with mitral regurgitation. And entrainment is when you have this high-velocity jet, which can recruit additional RBCs into your regurgitation jet, so the jet appears larger than it truly is. Coanda effect is one that we discuss frequently, and that's when you have a wall-hugging jet. And the principle is basically the fluid is attracted to a nearby surface, and the friction as a result of that can slow down the jet velocity. And since your color Doppler is a velocity map, then that would lead to underestimation of MR just by assessing your color Doppler. And this is an example of a wall-hugging jet, which is posteriorly directed by TE and by TEE. Vena contracta, which is the narrowest part of the jet, is another parameter you would measure in an attempt to determine the severity of mitral regurgitation, and you do it in the peristernal lung axis view. PISA, or the proximal isovelocity surface area, is a method we emphasize, and it's emphasized by the guidelines, has limitations, but if you have a good way of measuring it, your views are optimized, the texts have shifted the baseline velocity and you have a nice hemispheric orifice, then this would be a very helpful method to use when you're evaluating your mitral regurgitation velocity. We're kind of wired to look at the LA and look at how big the jet is in the LA, but always look proximal. If you have a large area of low convergence, even though if you're not seeing much jet in the LA, that usually indicates that there's significant mitral regurgitation. So don't always just look at the LA, look proximal, look at the area of low convergence, and when it's sizable, especially when you don't have any baseline shifting in your velocity, then look carefully for significant MR. And to determine the regurgitant flow, it's 2 pi r squared times the aliasing velocity. And to get your effective regurgitant orifice area, you would divide your regurgitation flow by the peak velocity using the CW of the mitral regurgitant jet. And to get your regurgitant volume, you would multiply your EROA by the TVI of that continuous wave Doppler jet that you get from the mitral regurgitation. So using PISA, you're able to determine your regurgitant volume and your effective regurgitant orifice area. Again, you want to make sure that your views are optimized, the baseline velocity is shifted between 30 and 40, and that you have a nice hemisphere to use. And we'll talk about the limitations in a minute. So what are the limitations of PISA and why can't we use it in every single case? So this is not applicable in multiple jets. So for example, if you have a case of Barlow's disease and you have multiple jets, you cannot just use individual PISAs and add them all together. It's less reliable in eccentric jets. It assumes a circular or hemispheric regurgitant orifice. So the equation basically assumes that your orifice is circular. So if you have non-circular orifices, then the equation would not be accurate, and we'll see some examples of that. Any small errors in measurements can lead to substantial errors in your evaluation of the effective regurgitant orifice area. And your maximal PISA may not always coincide with the maximal velocity of the MR jet, especially if you don't have a holosystolic mitral regurgitation jet. So these are some of the limitations of PISA. So we have multiple tools to use to evaluate MR, and your role is picking the right method for the right patient, considering the limitations, looking at the quality of the images, and determining which parameter you're going to use in which patient. And not all mitral regurgitations are created equal. So this is an example of 3D imaging of the vena contracta area in primary versus secondary MR. And you can see that in primary MR, the orifice is kind of circular, but in patients with functional MR, then that orifice is more elliptical. So that means if you just assume that there's a circular orifice and get your radius, you might be underestimating your MR severity using the PISA method. So keep that in mind when you're evaluating patients with functional MR. Volumetric assessment is important when you're also evaluating mitral regurgitation, again, based on the quality of the tracings. You can get the mitral regurgitation volume by subtracting the stroke volume from the LVOT from the stroke volume from the mitral valve annulus, and the difference will give you the mitral regurgitation volume. The limitations of this method is that you cannot use it in patients with combined MR and AI, because that would affect the calculations. Makes the same assumptions that the annulus is circular for the mitral valve and the LVOT, and small errors in measurement can lead to substantial errors. This other volumetric method kind of mirrors the MRI method of evaluating mitral regurgitation. You would get your stroke volume using the biplane method, and then you would subtract your LVOT stroke volume from that stroke volume you're obtaining from the biplane method. And that would give you your mitral regurgitation volume, and using that you can get your regurgitation fraction. Limitations is, again, foreshortening. If you don't have good apical views, you have foreshortening, the volumes might not be accurate, and sometimes you need contrast to be able to visualize the endocardial border. So this is, again, very similar to the MRI method. And when you're looking at an echo and your EF is normal, and you look at the LVOT stroke volume and that's slow, even though the EF is normal, always suspect MR. Because again, if it's not going through the LVOT, it's probably going through the mitral valve. So this is always a hint when you're reading an echo and there's some MR and the LVOT stroke volume is low, look for significant MR to account for this, for the low stroke volume in the LVOT. Jet characterization, including the timing, is again an important part of quantitation. So this is an example of mitral valve prolapse. Again, as demonstrated previously, you don't have much flow in early and mid-systole, and the MR is happening in late systole, and this is reflected by the continuous wave Doppler jet. And this is important to consider because in patients who don't have hollow systolic MR, if your MR is only mid to late systolic, then you cannot rely on a single measurement that you're doing using a single frame, right? Because you're assuming that whatever you're seeing in mid to late systole is occurring through the cardiac cycle. So if you look at this patient and you use the PISA method and you just use one frame in end systole, then your effective regurgitant orifice area is going to be 0.33. But then if you incorporate the TVI, that is demonstrating the mid to late MR jet, then your regurgitation volume is actually in the mild range. So in patients with mid to late systolic MR or patients with non-holosystolic MR, remember that you cannot rely on a single measurement using a single frame, because then you're making the assumption that this MR is happening throughout the cardiac cycle. And diastolic MR is also important to recognize. And you can see it right here. And this occurs when your LV-EDP is more than the LAP. And this is seen in patients with advanced AV block and severe aortic regurgitation. And you can get that diastolic mitral regurgitation jet. And the guidelines emphasize this multi-parametric approach to MR evaluation. So you have specific criteria for mild MR, specific criteria for severe MR. The criteria for mild MR include a small narrow jet, a vena contracta width of 0.0 centimeters or less. PISA radius is absent when your baseline velocity is between 30 and 40. If you look at the pulse wave across at the leaflet tips, then you have a mitral A wave dominant flow. And when you have a soft and incomplete regurgitant jet. For severe MR, the specific criteria include the presence of a flail leaflet, a PISA radius of more than 1 when your velocity is between 30 to 40 centimeters per second, when the jet area is more than 50% of the LA, when there's pulmonary vein systolic reversal, and when you have an enlarged LV with normal function. And these pertain more to primary MR. So whenever you have these specific criteria, you want to think about significant mitral regurgitation. And if you don't have enough specific criteria, then you have to quantitate using one of the methods that we discussed based on the quality of the images and the tracings. And the definition of severe MR is when your effective regurgitant orifice area is more than 0.4 centimeters squared, when the regurgitant volume is more than 60 and regurgitation fraction more than 50%. And there are special considerations in patients with functional MR. And the mitral regurgitation in such patients is usually, you'll get lower mitral regurgitation volumes because you're dealing with low flow states. So you're unlikely to get the regurgitant volumes of 60s and 70s like you do with primary MR because you're starting with a low flow state to begin with. And the EROA is elliptical or crescent shaped rather than hemispheric or circular, like we demonstrated by the 3D study. And this can lead to MR underestimation if you're using the PISA method. Functional MR also has a biphasic pattern in systole where it peaks early and late in systole to respond to the dynamic changes in the transmitral pressure. And if you look at the guideline specific criteria, there are some parameters that you cannot really apply to patients with functional MR, such as normal LV size and function, mitral ENA patterns, pulmonary artery pressure, because all these are affected by the underlying cardiomyopathy and the filling pressures, so they're less indicative of the severity of mitral regurgitation in patients with functional MR. What are the consequences of mitral regurgitation that you can detect by echo? Again, more specific to primary MR. So when you see evidence of LA enlargement, LV enlargement, LV systolic dysfunction, and pulmonary hypertension, always consider that the lesion that you're dealing with is actually hemodynamically significant. And this is a case of a 46-year-old male who presented to Valve Clinic with dyspnea. You can clearly see that there's evidence of posterior leaflet flail, but this echo also demonstrates that there's LV dilation, LV systolic dysfunction, and you have that eccentric jet. And in this patient, the PE pressure was high. So when you see evidence that there's adverse remodeling of the LV, there's LA dilation, pulmonary hypertension, always suspect that your mitral regurgitation, especially in primary cases, is hemodynamically significant. And these are the guidelines for the management of primary MR. So you would treat severe symptomatic MR as a class 1 indication. But in patients with asymptomatic severe MR, then you'd look at the EF being less than 60% and systolic dimension of more than 4 centimeters, or in the presence of progressive increase in LV size or decrease in your LVEF. And these are all parts of your echo report, and those would help drive the management plan. Secondary MR starts with GDMT supervised by a heart failure specialist. So when you see severe functional mitral regurgitation, the first step is GDMT, and then reevaluate the MR when the patient is medically optimized. And you would consider transcatheter edge-to-edge repair when you have a favorable MV mitral valve anatomy. We'll have a separate talk on that. When your EF is between 20 to 50%, when your end systolic dimension is less than 7 centimeters, and when your PA pressure is less than 70. So again, these need to be part of your echo report, because again, those will drive your management options. So we've discussed the role of echo in mitral regurgitation, but when would you use MRI? And Dr. El-Tallawi will elaborate further on this. When you have multiple mitral regurgitation jets, when you have eccentric jets that are challenging to quantify by echo, when you have discrepancy with the clinical findings, you're getting moderate MR by echo, but the patient's very symptomatic, you would go to a TE or MRI evaluation to kind of resolve this discrepancy. If you want to quantify cardiac size and function, if you want to evaluate LV scar, which has prognostic implications in patients with mitral regurgitation, and finally, when you want to evaluate patients with multivalvular regurgitation, patients with AI and MR or multivalvular regurgitation, where our quantitative methods cannot be used. So take-home points, you want to define the mechanism of MR, determine the severity, evaluate for the consequences, and use TEE or CMR when the mechanism or severity are indeterminate by TE and where there's discrepancy with the clinical findings. Thank you.
All right, moving on with those timely indications for MRI. How do we use MRI for evaluation of mitral regurgitation? So as for the outlines, we're going to show the indications, and then mitral regurgitation, how do we assess the lesion, quantification-wise, mechanism-wise, and most importantly, consequences. I think MRI is very powerful when it comes to the consequences of the regurgitant lesions. And then we'll show some studies about comparing MRI to echo, and finally some strengths and limitations. So first with the MRI indications, again going with what Dr. Faza just mentioned. If we have suboptimal echo images, if we have some discrepancy between the echo and the patient clinical status, some discrepancy within echo studies themselves, or if we have multiple valvular lesions also that was mentioned, consider MRI, okay? So how about lesion quantification? So all the guidelines obviously agree that severe mitral regurgitation is whenever you have more than 60 mLs by volume and more than 50% by fraction. However, those guidelines do not distinguish between primary and secondary MR. Obviously, if you have a ventricle that is big with low EF, getting to 60 mLs is very difficult, but getting to 50% becomes easier because the stroke volume is low. So as a general rule of thumb that I always mention, because patients don't have to always be in the same bucket. It doesn't have to be always more than 60 mLs, more than 50% for severe or for moderate or for mild. They could be in different grade zones. So, but for primary MR, focus on regurgitant volume because most likely patients will get to the 60 mLs before getting to the 50%. And secondary MR is the opposite because it's difficult to get to 60 mLs when your EF is 15%, unless the ventricle is huge. But you will most likely get to 50% because your stroke volume is low, right? It's in the denominator. So always put more weight on the fraction for secondary MR and more weight on the volume for primary. So how do we quantify by MRI? I'm going to list all the methods. So on echo, obviously, we have the PISA and the volumetric. On MRI, they all revolve around similar kind of similar tools. The most common is the one that I also recommend we use on echo is the total LV stroke volume, and then we subtract the aortic forward flow. That works every time, works if you have AR, doesn't care about the lesion, doesn't care how many jets, doesn't care about the mechanism. You just subtracting two volumes, essentially. The other one, if you have, sometimes patients have mitral valve SAM, they have turbulence in the LVOT or in the aorta, capturing the flow there becomes challenging, so we use the PA flow. Obviously, in the absence of significant PR or shunt, that could be probably very similar to the AO flow or LVOT. It can still be used. people with arrhythmia with AFib, where everything is messed up on all modalities actually, we can always use LV stroke volume minus RV stroke volume. Why? Because they're captured in the same beat, whether irrespective of the prior RR interval. So they're captured on the same beat. So you can always, subtract the two and get a feel. The challenging issue here is because you're tracing the ventricles and trabeculations becomes tricky. Number one. Number two, patients with AFib have lower spatial resolution because of the nature of the imaging. And number three is if you have another lesion on the right side, let's say you have MR and TR, that will take away from that difference. And if you have MR and AR, the difference will be augmented by both. So you have to kind of report it as such based on that. But most cases that we see are isolated lesions, so it can still work. So the way we calculate fraction, we divide the regurgitant volume over the total stroke volume. And then if you have aortic regurgitation, you have to subtract it from the total stroke volume in order to capture that flow going through the mitral annulus, because this is how the regurgitant fraction is defined, right? Is the flow going in the opposite direction divided by flow going in the right direction. So how do we calculate the total LV stroke volume? This is the true Simpson method, summation of discs, but instead of echo tracing on the apical and then the software will give you those discs, here we have the discs as slices, and then each slice is traced from base to apex in diastole and systole, and then we get the total volume and the EF, and then we get the flow. Typically we can get it again through the aorta, at the ST junction, or through the LVOT. So you see the tracing here of the flow on the y-axis, and over time you integrate flow over time, you get the stroke volume, you subtract those two, and then you get that mitral regurgitation. In this case here, 144 is the total output of the ventricle, 90 is the output into the aorta. The difference is 54, so that's in the moderate to severe range by volume. And then if you divide the 54 over the 144, the total output, that gives you 38. So this is maybe moderate to severe, depending on the mechanism, right? So if this is primary, I would probably call it moderate to severe. It's approaching 60 quickly, but the stroke volume is high. That's why the fraction is still on the lower end. Again, so this is, as I mentioned before, this is how the PA flow is obtained. Very similar, right? It's usually within 50% of the AO again, so that can still work. Another way, for the sake of research, I'm putting this slide, we don't use it, but we can also obtain an anatomic orifice area, right? On echo, you get an EROA, you can get an AROA on MRI if you do those thin slices at the mitral orifice. The thing is, this can only work if you have secondary MR, where the orifice is flat with the annulus, right? But if you have, let's say, a flail, the orifice is almost 90 degrees with the annulus, so slicing becomes challenging, right? So this can work in secondary, but again, I think with volumetric, we don't need to do this in particular. So now, this is how we quantify. Now, how we get the mechanism, right? We need to say this is severe MR, and then next say what is the mechanism of this severe MR. But before identifying the mechanism, you need to have good knowledge of the mechanisms, right? Understanding them, seeing them. So primary MR, secondary MR, these are the two big buckets. Within primary MR, we have obviously the myxomatous degeneration is probably the one that you will see the most. Obviously we have, and I'm going to show examples almost of each, how they show on MRI. They have degenerative changes, calcifications, infections, inflammations, right, congenital. And secondary MR is mainly annular dilation because of the ventricle or ischemic or atrial MR. Primary MR, this is the one that you're going to see the most, right? So I want you to know the distinction between those two because these are not the same disease, right? So you have fibroelastic deficiency on one end, you have Barlow's on the other end. So these are two different diseases that manifest eventually almost the same, i.e. with flail. Fibroelastic deficiency, you don't see prolapse. Fibroelastic deficiency is a disease of the old. It's, as the name indicates, deficiency of collagen tissue that leads to eventually flailing, cord rupture and flail. Typically the flail is focal and it's just flail. There is no prolapse, right? Prolapse, on the other hand, is excessive tissue. The leaflets become spongy and thick and redundant, and then you have prolapse that leads to flail. So whenever you see myxomatous degeneration with flail, usually there's a prolapse with it. Whereas fibroelastic deficiency is this older patient who has like thicker calcified leaflets with the focal flail, but there's no prolapse. So lesion localization on MRI. Obviously on echo we know we do 3D TEE and it's perfect, and you know this is P3 or A3 or whatever. On MRI you can do the same. So you can either do it this way, where you obtain a slice at the level of the mitral valve, similar to if you have enough experience, this becomes similar to a 3D surgeon's view of 3D TEE, right? So here you can see, obviously this is different, so the appendage is up there. So A1, P1 are here, and this is A3, P3. And then, so in this case, for example, it was a P3 flail. I mean, I don't know if you can see it, but with experience with MRI, you will see it. But we have also other ways that are more systematic, if you will, where you can slice that annulus from medial to lateral with multiple. Here I show 3, but usually we obtain multiple. And then for each one, you will have the corresponding log axis view, right? And then based on that, you can tell on this one, for example, at the bottom, that you see the flail happening here and the jet is posterior. So you infer, and you know, this is a zoomed out, zoomed in image, showing you how there is an A3 flail, right? So this is the green that is slicing here at the medial, and then showing you the posteriorly directed jet, and then you can see A. So this is another way that we do it. Okay, and this has been studied against TEE, and we're using surgery as a gold standard. So patients going for surgery underwent both modalities, and the accuracy is pretty good. However, where MRI is lacking is it doesn't see any rapidly moving small structures, in this case flail. So if you have a cord, MRI will be inferior obviously to TEE to see it, because TEE is a real-time modality, so the cord will be seen in real time. As you're seeing the screen is being obtained, whereas on MRI, the image that you see is an average image over multiple beats, and anything that moves randomly within multiple image, it will average as nothing, right? Because it's not in the same location to give you enough signal. So that's why MRI is inferior specifically for, and that's the same reason why MRI cannot see wiggling vegetations and these like small moving structures. Few examples how we see them on MRI. This is a primary MR, calcified, right? So you see the mitral. So calcium on MRI is dark, no signal. So this is MAC, here you see it. And this is a thick calcified leaflets, and you have the jets. So these leaflets become lumpy, bumpy, calcified. They don't stick together well, and you will have gaps that will lead to mitral regurgitation, right? This is a rheumatic disease with rheumatic mitral regurgitation. Obviously, MS usually is more of a concern here, but obviously this is mitral regurgitation, and you can see, hopefully you can see the hockey sticking, because the commissures are fused, so you only have A2, P2 to kind of open, but they're limited, so like they flip like a hockey stick. This is, as you can tell, a very advanced example of ischemic MR. I'm going to show the next one. You'll see the scar. So you have the scar, the infarct. Look at the posterior leaflet. It's just sitting there in one direction, just not moving. The anterior leaflet trying to get there does not coapt. And you have this posteriorly directed jet. Some in the past used to call this relative prolapse of the anterior leaflet, but it's not truly prolapse because it's not crossing the annulus, but it's crossing the posterior leaflet tip, right? This is an example of a true secondary MR that is non-ischemic. So in this case, you have annular dilation because of the ventricular dilation, tethering of the leaflets down. So like they're pulled, the paps are pulled down, everything, the cords are pulled down. The leaflets are tenting to the apex, towards the apex, and they can't come together, and you have this more central jet, right? So sometimes just having the eccentricity of the jet can guide you as to the etiology. So if you see some secondary MR with more eccentric jet, sometimes you want to go back and check the wall motion in that lateral wall, right? Mid-base lateral wall, you might have missed it. There's an infarct there. Again, secondary that is more dilated cardiomyopathies are more central. Atrial MR, which I hope you listen to the podcast. But atrial MR is it's a new kind of entity. We're still the mechanism is not simple in atrial MR. There are many proposed mechanisms for it. Mostly we say it's the annular dilation, but typically this profile of patients are older patients, diastolic dysfunction, develop a fib, the atria dilate, they pull on the annulus, the leaflets. But the difference here is that compared to ventricular secondary MR, they look at the leaflets, they coapt up towards the annulus, whereas in secondary from the ventricle, they tent down towards the apex. So that's something you can think about. But obviously, losing atrial contraction by itself can contribute to ventricular leaflet malcoaptation. So restoring sinus rhythm is important. Surgery have been tried, but obviously these patients are older, not indicate or like high risk for surgery. Clipping has been done, and they showed good outcomes, even better than ventricular secondary MR. Again, few examples: systolic anterior motion. Okay, so this is kind of a type of secondary MR in a way, right? You have mitral valve SAM, the anterior leaflet is touching the septum, creating a gap. You have this posteriorly directed jet. You can see it nicely on MRI. This is a case of endocarditis with perforation, right? Probably there's a windsock here that MRI did not capture, but we see at least where the jet is going through the mid of the leaflet, the center. And then this one here is a congenital type of MR, right? Anterior cleft. Think of this when you see somebody young, normal EF, central jet, and there's no reason for a central jet of significant MR. Always think about it. Difficult to capture on TTE, probably you'll have to do 3D TTE to see it, or if you have good 2D TTE, with good expertise. All right, so these are the mechanisms. As you can tell, most of the time, vast majority, we can get it on MRI, and that's enough. Consequences, as I mentioned before, is one of the strongest features on MRI. So what are the consequences? Remodeling, right? So these are most of the triggers for intervention are related to remodeling and function, right, besides symptoms. So as I said, the ventricle, we can easily get the end diastolic volume and systolic volume and accurately. Similar for the LA, right? So we use the Simpson method for the true Simpson, meaning discs for the ventricle. For the LA, we use the biplane area length method, which is the exact same that we use on echo. But on echo, we usually use single plane area length method, but that's the same formula. The difference is that on MRI, the cutoffs for the upper normal are 52 to 63 is mild, to 73 is moderate, above 73. This is indexed. 74. So echo is like 34. The reason for that is most of the time on echo, we foreshorten the atria, right? When the techs are doing the scans, they put the probe in the apex, focus on not foreshortening the ventricle, but frequently foreshorten the atrium. I think that's the reason why the atria are typically have a lower. But I think you get a lower volume, but you get the right bucket. So if echo called it severe because it's 55 mLs per meter squared, this is probably severe, but in reality it's 75. So the bucket is probably correct, but the number is underestimated. CT obviously have even higher cutoffs. I don't know if they have established cutoffs, because it's difficult to get normal volunteers to get radiation and get a CT, but CT doesn't assume with the biplane. It's a 3D, so it's less assumptions. It will capture the volume even more. Why is this important besides the remodeling? There's this concept I wanted to touch upon, which is the proportionate, disproportionate ventricular secondary MR. And this kind of came after these famous trials of COAPT and MITRA-FR. Why was COAPT positive? Why was MITRA-FR negative? And the reason being is we started to identify these two populations of secondary MR, right? We call them proportionate and disproportionate. So think of proportionate as I showed this dilated cardiomyopathy, the ventricle is dilating, is pulling on the annulus, pulling on the leaflets, and there's this symmetrical pulling of the leaflets away and then mitral regurgitation growing with it, right? Disproportionate is there is something asymmetrical about the tethering, so there's some ischemic component here and there where the MR is disproportionate to just being related to LV dilation and tethering. There's something else going on, right? So those benefit more from intervention. The others, the proportion benefit more from GDMT or GDMT only. So why am I saying this? Because on MRI, we can gauge that or measure it objectively. And there has been studies looking, trying to get this proportionality by using the ratio of the regurgitant volume over the LV size, right? So if there is symmetrical, if there's the regurgitant volume is growing faster than it should be, you will have a higher ratio of that. So for example, some studies looked in primary MR as an example. What is the ratio of regurgitant volume over the end diastolic volume, right? How much of this MR, what is the percentage of this MR compared to the LV size? How much is the LV size growing compared to this MR? For primary, it's almost 30%. So typically, if you have, for example, this is what it's this saying, if you have a 60 mLs MR, your ventricle should be about 200 cc's, right, on average. Whereas if you have secondary MR, those dilated proportionate, the ratio is 12%. Meaning if you have 200 cc's MR, ventricle, you're probably talking about 25 cc's MR. But that 25 cc's might be 50% fraction, right? So these are the proportionate. When this parameter was applied on the coapt and mitra FR, they found the mitra FR ratio was 0.18, meaning these were more symmetrical proportionate. Coapt was 0.31, similar to primary. So this, why is this important? Because on MRI you can get this and you can get this and you can do the ratio, and that's important. Why? Because you get this study. It's good to see this, to report it. So because probably it will help the ordering physician know whether this patient will benefit. Do they land in the coapt zone here of the disproportionate MR, or do they land in the proportionate MR zone where probably intervention might not help much, just GDMT. Okay, and this is something you can do on the echo, right? There's nothing. Typically, they have been done on echo, but using EROA over EDV, which is the same thing, EROA over EDV ratio, but the numbers obviously are different. But this is something to at least think about. Besides those remodeling, we have also things that are unique to MRI, like the ECV or extracellular volume. Obviously, we're trying always in medicine to find markers that will, predict which patients, the prognosis of patients at the earliest possible, right? Instead of waiting for symptoms or ventricular deterioration. So this is one such marker, right? So ECV, how much there's expansion of the extracellular volume, and multiple studies so far, including this from our institution, showing that even for the same mitral regurgitation level, if your extracellular volume is high, you do worse. And it was an independent predictor. Besides that, obviously you are very much aware of LGE and myocardial fibrosis, and specifically in mitral valve prolapse. So I made this diagram here as a kind of mechanistic way to show why it happens. It all starts essentially with the leaflets prolapsing. Those will tug on the paps. The paps will pull on the posterior wall, and then you have this hyperdynamic basal posterior wall. This is reflected by the Pickel-Hobby sign, and you see it visually. And then usually you have these high tension areas, if you will, where we see frequently scar in the papillary muscles. We see it here at the insertion of the papillary muscle, where you see it very nicely here. You see this, even this hinge, and you see the LGE at the bottom, right? So this is very important in MRI, because also this has been shown to correlate with outcomes. A lot of those patients come, they have arrhythmic symptoms and established arrhythmias, ventricular arrhythmias. So this is important. We don't know yet whether fixing the valve will fix this. And this again, it was known, but our institution did a big study on this to kind of establish its prevalence and distribution. Again, you will mostly see it in the basal inferolateral, basal inferior, basal to mid, and it's related to the severity of mitral regurgitation in mitral valve prolapse, but not related or not significantly prevalent in non-prolapse mitral regurgitation. And I think the reason it increases with increasing mitral regurgitation is because the more you have mitral regurgitation, meaning the more you have advanced mitral valve prolapse, meaning the more you have prolapse, the more you have tension on these paps, the more likely you've been having prolapse for more time. So that's why probably you have more prevalence up, if your fraction is more than 50% of those had replacement fibrosis, right? So this is something we have surrogates on echo that we can use, that again, the Pickel-Hobby sign on echo. There are other signs that if you see, they've been found to be correlated with LGE on MRI. Finally, which one is better, CMR or echo? I think they're both they're both as good, but I think you need to know which study to order for which patient, right? If the echo quality is not good, obviously echo will not be as good, and if you don't have expertise at reading the echo, obviously it will be inferior to MRI. And unfortunately, a lot of the studies, I think, in this field, sometimes people do those studies going with a bias towards one or the other modality. And the best way to show your bias is to do a great job in one modality and then a mediocre job in the other modality when you're analyzing those, and then you show difference. So again, if you do the appropriate indication, the appropriate study, I think both are as good. So this is one that used echo versus MRI. Obviously, you need the gold standard, right, to say, okay, this showed 60 mLs, this showed 30, which one is correct, right? So this one, the gold standard was for people who underwent surgery and then they had an MRI after the surgery, how much there was remodeling between before and after. That amount of remodeling, how much the ventricle got down in size was the gold standard, right? Because if you started with severe and your size, the LV remodeled significantly versus echo was 30, then probably it was severe. The MRI was right. And this is what they did here, where correlated the regurgitant volume of MRI with the post-surgical decrease in LV EDV. And you see the correlation is strong, whereas on echo is all over the place. Echo here, they used PISA only, right? So, and these were primary MR. And then you've all read echoes, primary MR, PISA, eccentric jets. It's all over the place. So I think, there's a message here, but also you have to look at it and then see, maybe the message here is don't use PISA for those cases. I don't know, but it doesn't mean that some people take the message that echo is that's it, and then immediately go to MRI. No, I mean you have to always interpret those studies correctly. This one here, similar. So these are patients who had echo, TTE, TEE, MRI within 24 hours. These are moderate to severe MR, asymptomatic. Now the question, how did they quantify the regurgitation by echo? They used the guidelines. So if you have more than 4 parameters, you're severe. If you have less than 4 parameters, they do quantification. The way they did quantification is by PISA. If PISA didn't work, they used the mitral inflow method. So, and they don't specify how much of those who had severe MR by criteria, how much distribution of each method. But this showed that at least the concordance between the two methods was 76% between echo and MRI, meaning 1 grade concordance. Discordance was in a quarter of the patients, and the reason, and this is I think the important message here, the most common reasons for discordance was when you have late systolic jets, multiple jets, eccentric jets, and these are the trinity of where PISA fails, right? If you have late systolic jet, PISA fails, multiple eccentric jets. So this is, I think, the message that is here. And then when they looked at the outcomes, obviously the red lines correspond to, so they combined, right, the groups, MRI severe, echo severe, MRI severe, echo moderate, MRI moderate, echo severe. So the red lines are where MRI is severe, the black lines are where echo is severe, and the outcomes obviously are in favor of MRI, right? So again, MRI is more reproducible, more accurate, that's for sure. And you have less variables to cause error, to put you to trick you into causing error. Whereas on echo, I think the reproducibility, the echo quality, and a lot of variables that you use that can, so by itself, obviously MRI, I think it is based on our experience, based on those studies, it is better, but it doesn't mean that echo shouldn't be used, or I think you should use it in the right place and use the right methods. Finally, this is close to my heart, and I want to put it there so that you guys are aware of that. I don't know why this is flickering, but the prolapse volume. So especially in cases who have bileaflet prolapse, Barlow's disease, remember those cases, like the leaflets are parachuting up into the left atrium, and then you have a gap, and then the regurgitation is going into the left atrium, the true regurgitation. We theorized based on this that prolapse volume, that blood that is situated under those parachutes, it's also going into the left atrium, right? And it's coming back into the left ventricle. Yes, it's not crossing the leaflets. Yes, echo is not showing it as a color, aliasing, whatever, but it's doing like MR, right? It's just simply staying there and coming back. So it's acting exactly like MR. So we theorized that MR should be both, right? The total regurgitation should be both. I mean, we shouldn't only focus on this. And what triggered this is that we saw a lot of those Barlow cases where, based on echo, or, we see this jet. It doesn't look significant, but the ventricle is dilated, right? So there's something going on. And historically, this has been seen, and people called it Barlow cardiomyopathy. If you look it up, because the ventricle is dilated. But personally, I haven't seen a cardiomyopathy where the heart function is normal, it's just dilated. Cardiomyopathy usually entails some form of dysfunction or restriction. So this is where this came from. What we did is we did the study where we quantified both. We quantified the MR jet and the prolapse volume, and then we checked how does it correlate with LV size, right? Which one is it the combo or only one predicts LV size? And I want to point your attention to this side over here. On the x-axis, we divided the groups into tertiles of mitral regurgitation, meaning the jet only, how much blood is crossing the leaflets, forget about the prolapse volume. So this group here is where the MR jet is less than 30, 31 to 49, more than 50, right? And then within each group of those, we added the prolapse volume, right? So some of them, let's say one patient here had a 25 mLs of MR, but they have a prolapse volume of 25. So the total is now 50, right? So within this group, we did the tertiles of prolapse volume. And then if you look, the more you add tertiles of prolapse volume, the bigger is the ventricle in each groups. So this is in each group. So this is telling you that the prolapse volume is loading the ventricle, is acting like mitral regurgitation. Why is this important? I think because most of those patients you will see an echo, right? You will see these bileaflet prolapse and you will see this MR. If you're gonna use PISA and report it, you're probably gonna underestimate the mitral regurgitation. So I would advise you to use volumetric assessment for those cases, either biplane, because when you do the biplane, you're going from annulus to annulus, and then the software is doing the discs. In diastole and in systole, you're not tracing all the way into the leaflets, right? You're stopped. So it's by itself is excluding the prolapse volume and the MR, and it's giving you the number. So, and in MRI, that's what we've been doing. So think about it when you have bileaflet prolapse. Finally, strengths and limitations. Dr. Faza already mentioned those. Strengths of MRI, no limitations from acoustic windows or body habitus. You can do as many imaging planes as you want, high signal to noise ratio, reproducible as we said. You can do again viability, scarring, flows, all the other consequences. Limitations is not obviously widely available. Patients' claustrophobia is a real thing. Now we have issues around it, but it's still happening. Implantable devices and CKD is no longer really an issue, at least here. Breath holding in some patients, especially if they have severe lesions and they can't lie flat. Arrhythmias are challenging in all modalities, I would argue. Again, cannot see small or irregular structures such as flail. We talked about that. If we have flow turbulence also in the LVOT, like in SAM, also we talked about that. We can always use other methods. And relatively limited, despite the data I showed you, it's still compared to echo relatively limited, but growing in terms of outcomes based on severity grading. And thank you for your attention. Any questions for myself and Dr. Faza? I can answer also on the echo if you want. She's giving me the blessing to answer echo questions. Yes.
Have you seen a situation in which you have, let's say, something like that, so you have a lot of prolapse volume, but you don't have a lot of MR in the patient that's perhaps like symptomatic or has some.
Typically, no. Typically, because remember, the more you have significant prolapse, the more likely this is advanced, the more likely there will be malcoaptation, at least in late systole, right? So yeah, I've seen mild, but I haven't seen zero with that. But I've seen cases where the MR was like 20 cc's, but the prolapse volume, I've seen prolapse, don't underestimate it. I've seen as big as 45 cc's of blood. So we've seen grades that where by direct MR is like mild, and you add the prolapse volume goes to severe. It can be that bad. And then in this study that I showed you, we did that. We tried to see like with and without what happens with the grade reclassification. 50% of the patients were essentially up-classified, right? Most of them from mild to moderate or moderate to severe, but there were a few from mild to severe. All right, back to work.